Hi, welcome to the February Rapid Update in Therapeutic News. So I'm going to give a brief overview of some of the national guidance published in the last 3 or 4 months. And we've seen several final publications with some substantial changes which are relevant particularly to primary care. So have a look at the NICE asthma, menopause and recurrent UTI guidelines, and then a few outcomes just from the SBOW report. So in November, NICE published its final version of menopause guideline update, and this includes new recommendations on the management of genitourinary symptoms. It gives the option of cognitive behavioural therapy to manage symptoms associated with menopause, particularly vasomotor symptoms, and the CBT there can reduce the sort of bother and interference from the symptoms in people's daily lives. NICE has put out a 15-minute podcast which gives more information on the update. Also on the website, there's a discussion aid, and that's neatly divided into the sections, so you can either look at somebody who's had early menopause or somebody who's needing estrogen only or combined HRT. So you can look at the right section and then look at the risks for specified medical conditions. So for example, here we've got the table from that guide looking at the risk of breast cancer. Moving on to the surveillance programme for antibiotic use and resistance. This was published in November 2024. And we know there's been increasing recognition and concerns about antimicrobial use and associated resistance. And we've seen big declines in the volumes of antibiotics used in primary care between 2014 and 2019. So unfortunately, we kind of lost that momentum, and there'll be many reasons for that, including the pandemic and the strep outbreak. But the total antibiotic use has increased to above the 2019 levels, and with the highest rate of use in those over 65. And we've also seen rises in Clostridioides infections. The SBAR report also highlights that people in more deprived areas are getting more antibiotics than those in the least deprived, and that variation is increasing. In terms of antibiotic resistance, bloodstream infections resistant to common antibiotics has increased by 3.5% since 2019, and E. coli bloodstream infections resistant to coamoxiclav remains really high, over 40%. But there are some quick wins and some relatively easy ways of reducing people's exposure to antibiotics and their risk of resistance. So this graph is looking at one of the national measures, total volume of antibiotics, and then course length of amoxicillin. So looking for 5-day courses. So here we have graph with percentage of amoxicillin courses issued as 5 days rather than 7 days. And then across the bottom we have the time as time goes on, and you can see that the red line there is Haldar, and there's several health boards who've managed to make quite significant impression on that percentage of people receiving 5-day courses. The report also highlighted a study which looked at the assessment of UK healthcare workers' knowledge, attitudes and behaviours on antibiotics, and that was from March. That study was in March 2024, and it showed that 91% of healthcare professionals had easy access to the guidelines, and approximately 73% had easy access to materials and resources to give to patients on antibiotic use. I suppose the question for us is, can we identify those colleagues in our team who can't easily access the formulary or resources? When they looked at barriers for providing advice, time, of course, was a very significant one of the common reasons cited, so in 28% of people. And obviously we are under enormous pressure, but I suppose the advice doesn't necessarily need to be time consuming, and you can see the Target website there for discussing antibiotics with patients, and backup prescriptions can reduce the belief in antibiotics. So really it's an opportunity for us to reduce the future consultation rate if we can find that time. You'll be familiar with the wealth of resources available on the RCGP Target Toolkit. The SBAR reports outlines how the patient information leaflets, text messaging of leaflets, and the UTI Flores proved particularly popular. They also noted that there's the how-to guides for people on long-term antibiotics, so particularly people with COPD and acne, and those guides support medication review. Moving on now to the NICE recurrent urinary tract infection guideline, which was updated in December 2024, and this is for women, trans men, and non-binary people with a female urinary system. And just a reminder that when we're talking about recurrent UTI, we mean people who've had 2 UTIs in the previous 6 months or more than 3 UTIs in the previous year. So this is my précis of the NICE recurrent UTI guideline and visual summary. So the big change here is to consider methenamine. So the wording of the NICE guideline is to consider methenamine hippurate as an alternative to daily antibiotic prophylaxis for recurrent UTI in non-pregnant women, and making sure that any current urinary tract infection has been adequately treated first, and that this is when to be considered when there's not been adequate improvement from behavioural and personal hygiene measures, from vaginal oestrogen or single-dose antibiotic prophylaxis, where those are appropriate or applicable. The guideline reminds us the importance of reviewing the methenamine, so initially at 6 months and then yearly, and if you're prescribing daily antibiotic prophylaxis, reviewing that every 6 months. So methenamine, lots of us won't be so familiar with that. Its indication is for an uncomplicated lower urinary tract infection. Methenamine hippurate is a urinary antiseptic, and it requires an acidic urine for its action. So the BNF says, it has a decreased effect on urea degrading bacteria such as Pseudomonas and some strains of Proteus. But these are the organisms that usually affect people with a more complicated urinary tract infection. So as I say, methenamine is for uncomplicated urinary tract infections. In terms of contraindications, people with gout or severe dehydration and adverse effects in the BNF are noted to be uncommon, but generally gastrointestinal, and also skin reactions have been noted. And lastly, the asthma guideline. So this is a joint guideline between NICE, British Thoracic Society and SIGN, and the final version was published in November 24. And it emphasises the importance of an accurate diagnosis and maintenance and reliever regimes. So in terms of diagnosis, NICE say obviously the starting point is a good history, but do not confirm a diagnosis of asthma without a suggestive history and a supporting objective test. So code as suspected asthma until the diagnosis is confirmed. If the diagnosis of asthma is confirmed, record the basis for that and in the person's medical records alongside that coded diagnosis. So this flowchart is available on the NICE website under the asthma guideline and the tab saying tools and resources. And there's a similar chart for children. So the top boxes give you the recommended order of testing. So first line would be blood eosinophilia or fractional exhaled nitric oxide testing. If that's not readily available, bronchodilator reversibility with spirometry. And if neither of those are available, then peak expiratory flow rate. And those yellow boxes at the bottom shows what you're looking for in those tests. So for example, the peak flow reversibility variation of 20% or more. For children aged 5 to 16, there's a separate flowchart, which is similar but without the mention of eosinophils. And the end of the options, it states that if asthma is not confirmed by these other tests, but still suspected on clinical grounds, either perform skin prick testing to house dust mite or measure total IgE level and blood eosinophil count. So, in terms of asthma treatment, a key principle of this guideline is not to prescribe short-acting beta-2 agonist inhalers to people of any age with asthma without a prescription of an inhaled corticosteroid at the same time. So not using the blue inhalers on their own. And if you came along to the Learning at Lunch in October, you'll have heard Dr. Katie Pink outline the marked regimes and provide the really useful rationale for this guidance. So NICE now recommends that people with newly diagnosed asthma who are 12 or over, we offer a low-dose inhaled steroid formoterol combination inhaler to be used as needed for symptom relief. But if the person's needing if the person presents very symptomatic or with severe exacerbation, then the advice is to start with low-dose maintenance and reliever therapy in addition to treating the acute symptoms as you would normally, so for example using oral corticosteroids. There's advice about stepping down, and then once you've stepped up for somebody, if you need to step up to moderate dose maintenance and reliever therapy and they are still not well controlled, then NICE recommends various options, including retesting and add-on therapy. But obviously, all this is very detailed, and I'd strongly recommend you look at the guideline. There's still the All Wales Medicine Strategy Group guideline is also still available. That will be updated in light of NICE, but I personally find them both helpful at the moment. Thank you. Other guidance you might want to know about is the endometriosis diagnosis and management guideline from NICE has also been updated, and there's a maternal and child nutrition very extensive guideline. So this has been a really rapid overview, but I hope it gives you a pointer to what's new and what's changed recently. Thanks for listening.